My name is Dean Huang. I work at King's College Hospital in London. And thank you for having me here today. And I'm recording this talk. And my topic will be on the application of contrast-enhanced ultrasound for intervention, including the application of intracavitary contrast-enhanced ultrasound. And it's a great disappointment that I won't be able to join you today in Shanghai, but I'm sure in a room full of ultrasound experts, if I ask the question, why do we use ultrasound for intervention? I'm sure many of you would have given me the answer such as ultrasound doesn't involve any ionizing radiation, it provides real-time imaging, and it's portable, and it can be performed at bedside for patients. And it has advantage specifically for intervention in that it provides multiplanar views for a target. It also gives us the opportunity to perform the examination multiple times without adding any harm to the patient. And I'm glad that you echo the sentiment about the benefit of ultrasound for intervention, and that is why ultrasound is a very popular modality for interventional procedures. The real question I want to address today is, why contrast-enhanced ultrasound? With such a good modality that we have in ultrasound, why do we need to add the ultrasound contrast agent? And I think ultrasound is good, but it's not without limitation. And the limitation may be based on its diagnostic value. It may not answer the questions that we want to ask for in determining whether a procedure needs to be done. There's limitation during the procedure that we may not be able to see the target very clearly. And finally, it may have limitation with regards to the patient that we're treating. And these limitations can only be addressed with a contrast-enhanced image modality such as CT or fluoroscopy. And it's with by providing the solution for these limitations of conventional ultrasound, contrast-enhanced ultrasound in intervention has gained its popularity, as well as its use in diagnostic field. Contrast-enhanced ultrasound has increased being used in interventional procedures as well, with accumulated experience culminating in various guidelines and recommendations in clinical practice. And it is based on these published guidelines, including the EFSOM guidelines, that I'm going to structure my talk on. Like any good interventional procedures, the key of success is to plan it carefully before you start. And with intervention with contrast ultrasound, we need to think about the application and the questions we want to have answers for. And contrast-enhanced ultrasound can be performed either intravascularly or within a cavity or intracavitary use of contrast ultrasound. For intravascular ultrasound, how do we do it at King's? It's very similar to how other diagnostic procedures are performed. For the intravascular ultrasound, we do them with a bolus injection of the ultrasound contrast agent intravenously. We usually record the images on a dual screen, and we record the cine loop and store the static images for record. And when used intravascularly, we can image the macrovascular structures such as blood vessels or other vascular image. And the key thing is that these microbubbles in the ultrasound contrast agent, they do not diffuse out of the circulation, and they behave as a marker for blood products. So that anywhere you see these microbubbles, they are in the compartment intravascularly. But the strength of the intravascular ultrasound is in its depiction of the microvasculature of tissues. One of the limitations of conventional ultrasound is its lack of ability to differentiate between tissue with different vascularity, and contrast-enhanced ultrasound has the capacity to emphasize the difference of microvasculature between various parenchyma and pathology. For the intracavitary ultrasound, the key thing is to provide an adequate dilution before you give the contrast into a cavity. The dilution that we use at King's is usually just from a single tiny drop of the ultrasound contrast agent Sonoview diluted in 40 to 50 mL of normal saline. And this provides adequate dilution without a high concentration of contrast, which may obscure your view to your target. And if you want to repeat an examination, it's important to remember to destruct and burst all these bubbles with high energy ultrasound pulse. For example, if you want to look at a bladder with contrast, you want to make sure you have destroyed all these bubbles that's already in the bladder before you repeat the examination again. So where can we use intracavitary ultrasound? In fact, microbubbles can be instilled into any body cavities, either pathological or physiological. So by this, we can use it in the GU systems, in the renal tract, in the biliary system, in the pleural space, and in the pathological cavities, we can instill them into abscesses or intra-abdominal collection. And this is gaining popularity. The intracavitary application can be used in isolation for intervention, or it can be used synchronously with this intravenous application that's well established. Talking about different procedures, one of the most common procedures that's performed under ultrasound guidance is biopsy. And I think before we start biopsy, contrast ultrasound has the added value in providing superior diagnostic ability, and it may help you to identify a lesion which demonstrate benign features and prevent you from performing an unnecessary biopsy or causing unnecessary complication relating to the procedure. For example, if you see the benign features in a benign liver lesion or a non-enhancing complex renal cyst, which is only filled with clots, you probably don't need to biopsy this, and you can avoid causing any harm to the patient. But once you've decided that you're going to go ahead with the biopsy procedure, contrast ultrasound firstly can help you to avoid any necrotic tissue and identify a viable tissue within the target lesion that you're biopsying. And this may improve your diagnostic accuracy. Here we have an example of a large renal cell carcinoma with a large necrotic center. By applying the contrast enhanced ultrasound, we can target our needle to the vascularized, viable portion of the tumor and get the accurate histology from the biopsy procedure. From the literature of biopsies for various organs and tumors, by using contrast enhanced ultrasound, it potentially could increase your diagnostic accuracy by 10 to 15%. It is also useful to identify a target which may not be easily identified on grayscale ultrasound. How does a contrast ultrasound help? So firstly, it may help you to see the lesion more clearly. Secondly, it may help you to identify additional lesions that you probably did not expect to identify initially, but become clearly visualized on contrast enhanced ultrasound. So here there's an example of a lesion which is not clearly visualized on the grayscale ultrasound. This is a renal lesion which can be seen on the CT scan, but when the patient had a biopsy on the conventional ultrasound, the biopsy came back as non-diagnostic. When this procedure was repeated on the contrast enhanced ultrasound, we can see that there's a more vascularized portion of the lesion within the lesion, and this area is probably more viable and was targeted for biopsy. And this returns a positive yield of biopsy of a diagnosis of papillary renal cell carcinoma. So this highlights the advantage of contrast enhanced ultrasound in identify a target which is more likely to provide you with viable tissue. Another way contrast enhanced ultrasound can help with your biopsy is that if there are additional lesions that's not easily identifiable on the grayscale ultrasound, it may become clearly visualized on the contrast ultrasound. So here we have multiple liver lesions within the liver. The larger lesions initially cannot be identified on the grayscale ultrasound, but by applying ultrasound contrast agent, we can actually identify this larger target, and we can then target this lesion and provide a better chance of getting a positive yield from the biopsy. We'll move on to the other common procedure that's performed on the ultrasound, which is ultrasound-guided drainage. Again, with drainage, the limitation is to identify the area which may look complex on grayscale ultrasound and differentiate it from the surrounding normal parenchyma. And contrast enhanced ultrasound, by the same principle, can identify the perfused tissue and separate that from the non-perfused abnormality. So here we have an example of a liver abscess. Liver abscess itself can demonstrate a variable and confusing grayscale appearances, and these appearances may even change over time. Whereas on contrast enhanced ultrasound, because abscess is avascular, we can clearly see the boundary and the size and the morphology of an abscess on the contrast enhanced ultrasound. If an abscess or collection is adjacent to a vital organ, again, contrast enhanced ultrasound has the added benefit in delineating the boundary, therefore help the operator to avoid damaging the underlying vital organs when you're trying to target this area for drainage. So these are the intravascular applications for drainage. But for intracavitary application, what we can do is by putting ultrasound contrast agent down through the drain that you have just put into the abscess. And by doing that, it'll help us to, one, to confirm the catheter is in the right place, and two, it will help you to delineate the morphology of an abscess or collection. And this is particularly useful if there are multiple pockets of abscess within the organ, and what you want to know is that your drain is effective in draining each pocket of the collection. And if you can see that when you put contrast down the drain, every single pocket or the satellite collection lights up with your contrast agent, you know that all these little pockets are in communication with each other, and your drain would be effective because you'll drain every single pocket that's in communication with where your drain is. And this is indeed one of the recommended use of intracavitary ultrasound. It helps you to identify your needle or catheter and delineate any cavities with a complex collection. I just want to give you an example of a slightly unusual case. This is an intracavitary ultrasound with the drain injected through a biliary drain. And I think for those who have more sharp eyes for contrast ultrasound, you may start questioning my statement that this is an intracavitary contrast ultrasound, because from what you can see here, not only that you can see the drain, but you can clearly see the enhancement of the surrounding hepatic parenchyma, which implies that there is enhancement of the microvasculature of the liver. How can this happen, or what does this mean? And in fact, this intracavitary ultrasound actually demonstrated a communication between the biliary tree and the hepatic artery. And this is a demonstration of a biliary arterial communication through the drain, and it's again confirmed by fluoroscopy, where we can get the same information and make the same diagnosis without performing fluoroscopy. And you can even perform this diagnosis, obtain this diagnosis at the patient's bedside. And this is the advantage of contrast-enhanced ultrasound. We'll move on to another common procedure that's performed under ultrasound guidance, which is a nephrostomy. And intravascular contrast ultrasound can improve visibility of the non-perfused target renal calyces, particularly in the presence of multiple clots or pus in the collecting system. And we can also optimize the visualization of our puncture needle by coating or filling the needle with contrast agent. And this is a very useful technique, and you can see the comparison between the ease of visualizing the needle with the contrast enhanced ultrasound compared to the grayscale ultrasound. And once we perform a successful puncture, we can get a positive visual feedback on the contrast enhanced ultrasound. So if it's a high pressure system, we can see the contrast being washed out by the urine as you make the puncture into the collecting system. So you see the microbubble refluxing back on your image. Alternatively, and more commonly, when you make the puncture, what you can see is that the contrast then flows into the renal pelvis and demonstrates the renal pelvis, showing you that you're in the right place. And by injecting a bit more contrast, you can actually visualize the whole renal tract all the way down into the bladder and confirm the successful drainage into the bladder by visualizing the microbubbles within the bladder. And in fact, we have compared the contrast ultrasound nephrostogram, and it shows that it can demonstrate the correct positioning of a nephrostomy tube and assess the drainage into bladder with comparable result to standard fluoroscopy. Again, a very useful tool that can provide you information without radiation or transferring patient to your fluoroscopy unit. Other application for contrast enhanced ultrasound for interventions is in the thermal ablation procedure for tumor. This applies for both in the hyper thermal ablation or hypothermal ablation, particularly in the kidney. So here we have an example of renal cell carcinoma ablation, and after the first ablation, and you can see on the images here, there's residual vascularization within the tumor. So the operator knows that there's a need for additional ablation, which then obliterated all the vascularization within the residual lesion. And I think before we focus on more procedures, I just want to bring us back and just take a little, just pause for a second just to think, why are we using contrast enhanced ultrasound for intervention? Because a lot of these procedures, including ablation, can be performed equally well with CT. And I think one of the reasons that contrast enhanced ultrasound benefit is because of the patients that we are treating. And these patients may involve these groups may involve patients with impaired renal function, where nephrotoxic contrast agent is undesirable, or it may involve children where radiation should be avoided, or it may involve critically ill patient where we would like to perform these procedures at the patient's bedside without moving the patient from one part of hospital to another part of hospital. So in terms of the renal ablation, these patients can be followed up with CTs just to monitor progression and looking at any recurrence. But in patients with impaired renal function, surveillance can also be carried out with contrast enhanced ultrasound. And here, what we are looking at is the vascularity of the ablation scar, and just making sure the scar is not growing and there's a continual avascular nature to the scar to help us to be reassured that there is no recurrence of this tumor. Again, looking at patient group at risk, clearly children and radiation is not a great combination, so we perform a lot of contrast enhanced ultrasound, particularly in the pediatric population. And just a little bit about how we do it. And I think for the intravascular contrast enhanced ultrasound, we give the dose, reduced dose compared to the adult, either based on the patient's weight or the age. For the intracavitary ultrasound, the diluted contrast technique is the same as applied in adults. And all the things that we talked about in terms of the application and intervention, such as for biopsies and drainages, can apply in the pediatric population as well. And one of my colleagues has looked at looking at chest drainage into empyema, and this is an example that she has demonstrated that by using intercavitary contrast enhanced ultrasound, she can show the effectiveness of a drain. If a drain is only in a locule of a collection, a drain, all the contrast agent that you inject through the drain will stay within the locule. Whereas if you see that, you can infuse some medicine to dissolve the septation, and once that's successful, you can see the diffusely spread out of the contrast agent once the drain is in a satisfactory position. I think this is just an example where contrast enhanced ultrasound can provide a unique solution in the pediatric population. And this is important because not only for the medical reasons, but when we as doctors face the parents asking us the question, doctor, is a CT scan safe for our child? We should be able to look at the patient, the parents in the eye and let them know that we have worked to ensure that the patient's irradiation exposure is necessary. And one of the alternatives we should think about is whether contrast enhanced ultrasound could be used instead of a CT scan. And finally, another risk, a patient group that's at risk is the critically ill patient, where if we can get useful information at the bedside, that can avoid the risk of transferring the patient. And we talked about the contrast enhanced ultrasound nephrostogram. This is an example of a contrast ultrasound nephrostogram performed at the bedside in a very sick patient. Here we can see there's a ureteric injury with the spread of contrast agent into a collection within the abdomen. But actually, following this in real time, we see these contrast agents spreading into a peristalsing tubular structure. These, in fact, are small bowel loops. So by performing a contrast ultrasound nephrostogram at the bedside, we made the diagnosis of a ureteroenteric fistula in this patient. So I just want to conclude by saying that with the addition of contrast agent, we can perform contrast enhanced ultrasound with added benefit in biopsy, in drainage, and also in management of ablations. But even before this, contrast enhanced ultrasound may tell you that you don't need to do any of these procedures. So these are very important. And these are important because you can achieve all of this without any radiation or added nephrotoxicity. And this is particularly important to consider when you're managing patients in the risk, with risk, such as patients with renal impairment, in children, or patients who a transfer may have added risk. So overall in my practice, and hope in your practice too, that contrast enhanced ultrasound can add a tailor-made solution to a complex medical or logistic problem that you may face in your medical practice. Thank you very much.